Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. If you are hearing this right now, then you are not currently a Journal Feed subscriber, and so will not be receiving the full Journal Feed podcast. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org. All right, this is the audio version of the past week summaries, which this week were brought to you by our authors Denrick Cooper, Catherine Solkowski, Ketan Patel, Millie Cosse, Jason Lesnick, Aaron Lacey, and of course, Clay Smith. Great, let's talk about the first article, which was titled Diagnostic Yield of 24 to 48 Hour Ambulatory Cardiac Monitoring in Discharged Emergency Department Patients out of the American Journal of Emergency Medicine. Now, identifying arrhythmias, of course, requires us to actually measure for them. And if you think about it, an ECG is only 10 seconds of cardiac activity. So the likelihood that you capture something that's more transient is relatively low. A lot of the bigger, badder stuff, of course, you're going to see on there because it's going to kind of be around all the time, or there'll be traces of it. But some things only happen intermittently with a normal ECG in between. In order to capture these things, we have Holter monitors. The exact diagnostic yield of a Holter monitor is kind of debated. Is it useful for me to send one from the emergency department, or can I just let the cardiologists deal with that kind of thing? Typically, a Holter monitor is ordered if the patient has had syncope, palpitations, or dizziness, but there's a host of other indications why you might want to get a Holter monitor. For example, some of the patients from this study had a suspected or confirmed TIA. And if they don't have atrial fibrillation, it's possible that they just have paroxysmal atrial fibrillation. And so you might want to rule that out as a potential cause for their stroke by getting a Holter monitor just to make sure that they're not sometimes in AFib and not feeling it. What these authors wanted to do was see how often is it useful to get a Holter monitor from the emergency department, and is there any difference between ordering a 24-hour or a 48-hour Holter monitor. This was a retrospective chart review of 491 patients discharged from the emergency department with a variety of presenting complaints, and there was a 24 to 48-hour Holter monitor that was ordered. They defined diagnostic yield as their primary outcome a little bit interestingly, very broadly from this study. Either a patient who had an arrhythmia who didn't notice, so a silent arrhythmia, that could be useful diagnostically. A patient who had a symptomatic arrhythmia, which is probably what caused their symptoms. I'd say that's probably the most useful case. And then patients who had nothing at all but had their symptoms, which means that their symptoms likely aren't caused by an arrhythmia. That can also be useful diagnostically. That last one is not always what we think about when we really think about diagnostic yield. So the outcome of diagnostic yield is kind of a broad outcome. Regardless, the overall diagnostic yield was 68%, which is quite impressive. And there was no significant difference between a 24-hour or a 48-hour monitor, which is also interesting. The rate of significant arrhythmias was 37% overall. Though given that the majority of silent arrhythmias were SVTs with no symptoms, and they didn't necessarily specify how long these SVT runs were, and if they're completely asymptomatic, you don't necessarily treat these things, then I'm not sure how important that contribution would be. Similarly, in non-sustained ventricular tachycardia, if it's asymptomatic, I don't know if that's causing their symptoms, but that probably warrants an echo to rule out structural heart disease, so I'd say that one's okay, that one's worthwhile. However, if you take out the asymptomatic SVTs, the clinical significance of which I'm not entirely sure because we don't have follow-up data on these patients, then the diagnostic yield falls from 68% to 42%. Not as good, but honestly still pretty good, although really being driven by these patients who have symptoms but nothing on the Holter. Especially if your patient came in for like a TIA, if you have a couple runs of SVTs, then I don't think that's going to be the cause for your stroke. All the same, if you're setting up this patient with some follow-up, this seems like it could be diagnostically helpful for the next physician who sees them. In a spoonful, there is certainly a place for Holter monitors, but I think that this study somewhat oversells it. Regardless, they're pretty cheap, certainly safe. I just wonder how much false positives we're finding there. Okay, let's skip to the fifth and final article, titled Evidence-Based Emergency Tracheal Intubations, out of the American Journal of Respirology and Critical Care Medicine. Over the last, let's say, 2 decades, there have been some advances in the understanding of how we should be intubating patients. And so this is a nice review about exactly what we've learned over that time. If you have not changed your intubation practices in the last 20 years, well, you're probably very unlikely to be listening to this podcast. But if that is you, then you should probably read this article. Why is all this important? Well, because 40% of intubations result in arrest, a saturation less than 80%, or hypotension. Or at least that's what's quoted from the article, which I'd say is not really my experience, but those numbers out there do exist, so it's happening to somebody. Okay, let's cover all the most recent recommendations that we have from recent trials. First off, let's try to avoid hypoxia. Now, unless you were living under a rock last fall, then you will have heard of the pre-oxy study, which has shown us, along with a couple of other papers, that non-invasive ventilation with a tight-fitting mask seems to be helpful pre-intubation. Also, in the period after you pushed the induction meds, and before you do the laryngoscopy, it is actually helpful for you to do BVM or BiPAP. Historically, this was avoided because they thought you would insufflate the stomach and it wouldn't be good, but you should actually be doing this. Next, we want to prevent hypotension. Now, there is no clear evidence that giving a prophylactic fluid bolus is helpful for this, unfortunately, and was common practice for quite a while for quite a lot of people. The evidence for prophylactic pressors, unfortunately, is still out, but there's an ongoing RCT looking at this, so hopefully we'll have some kind of an answer in the near future. What about the medications that you want to pick? Well, in the emergency department, etomidate and ketamine are kings. There are, of course, some concerns with etomidate in some clinical circumstances where you might not want those adrenal glands suppressed. However, it's not completely clear that it's inappropriate. Personally, I go with ketamine, but if etomidate is your thing, then, no one's going to really fault you for it. The same goes for neuromuscular blockade. Succinylcholine or rocuronium are both good choices. Both have their little benefits here and there. Succinylcholine, of course, has more contraindications, but rocuronium was associated with some awake after paralysis in the recent years, so they both have a bit of their downsides. However, if you sedate properly, that one shouldn't be a problem. Finally, of course, there's laryngoscopy and how you're going to pass that tube. Video laryngoscopes are superior in every way, in every scenario, even contaminated airways. Just in that circumstance, you have to keep in mind that, yes, perhaps you'll have to use a more direct view if you can't keep the camera clean. However, it's not necessarily better to start with direct, even in that circumstance. As for passing the tube, a bougie seems to be quite similar to using a stylet in your ET tube. You should not be trying to use an ET tube all by itself, so either pick a stylet or a bougie. Okay, let's run through all of that in one quick, just sort of verbal, how you're going to do an intubation. So if you decided to do the intubation, you're going to pre-oxygenate by putting your patient on BiPAP. Good. You're going to do this for about 3 to 5 minutes to get that pre-oxygenation as high as possible, 10/5, 100% on your BiPAP. Then you're going to push your induction medications, etomidate or ketamine, and paralyze them with succinylcholine or rocuronium. And while they're kind of getting all loosey-goosey ready for you to intubate, you're going to bag mask them. It is at this point that if you're concerned for hypotension, that you could do a dose of push-dose pressors, although the evidence is not clear on that. However, it won't be beneficial for you to give fluids. Then once all that's done, great, let's use a video laryngoscope to look at the cords, and then you can either pass an ET tube with a stylet or a bougie before your tube. Finally, you confirm where you're at using end-tidal carbon dioxide monitoring or a waveform capnography, and you are good to go. In a spoonful, that is how you thoughtfully intubate a patient using pretty much all that evidence-based medicine has to offer from the last recent years. I would also like to mention that the journal feed has covered pretty much every important paper that Holters, how you might intubate a patient, and the last quite a while. So just keep following the journal feed and you'll be good to go. Okay, let's do a wrap up of everything we talked about today. From the first article, Holter monitors seem to do a pretty good job, and even at 24 hours when ordered appropriately from the emergency department. And then from the fifth article, we covered an evidence-based medicine guide to intubation. All of the latest research summarized into one nice little paper. Again, if you are hearing this right now, then you are not currently a part of the members feed, and so you missed 3 articles that we covered from this past week. 1 was about, do we really need to give antibiotics for nasal packing? 2 was ACEP's new policy on carbon monoxide poisoning and hyperbarics. And then the last article you missed was whether or not we're overdoing it with antibiotics for suspected sepsis. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.